So let's continue the discussion of the inflammatory response and the immune response. If we look at the sequence of events in the inflammatory response, how does inflammation start and continues? The mast cells, as I mentioned earlier, are the first cells to respond, and they will recognize any tissue damage, whether this tissue damage, because any tissue damage has a unique molecular pattern that is different from the molecular pattern of normal tissue. So mast cells have receptors known as pattern recognition receptors. These receptors know what is the normal pattern. And if they identify a damage-associated molecular pattern, DAMP, or a pathogen-associated molecular pattern, PAMP, immediately these receptors will send an alarm. And this will scare the mast cells. What happens to an octopus if you scare it? It's going to shoot its ink. And what happens to the mast cells when they get scared? They shoot chemicals, granules inside them, and these granules have a lot of histamine and prostaglandins. This process is known as degranulation of mast cells. And it is histamine that will induce the vascular changes that result in many of the inflammation manifestations, because histamine will result in vasodilation and increased capillary permeability, which means more blood will go to this area of tissue damage or tissue invasion. And the increased capillary permeability will allow fluids and chemicals and water to ooze out, and this will result in more delivery of blood cells and proteins, as well as exudation of fluid, and that site, the inflamed site, will become hot, red, tender, swollen. And these are the four cardinal manifestations, the four cardinal local manifestations of inflammation. Any inflamed tissue is hot, red, tender, swollen, and that's a histamine effect on blood vessels with vasodilation and increased capillary permeability. The complement, which is nothing but plasma proteins, they circulate in an inactive fashion, but the complement will become activated either by the pathogen or by antibodies, and the activated complement will have four functions. Chemotaxis, which means it chemically attracts the white blood cells, the neutrophils, the basophils, the eosinophils, and macrophages to the site of inflammation. Anaphylatoxic effect, which means more stimulation of the mast cells to result in more degranulation and histamine release. Opsonizing, which means tagging or marking the pathogen to facilitate its phagocytosis by the macrophages and neutrophils. So they mark the pathogen, this is the bad guy, kill it. And finally, they themselves can attack the pathogen, and they have lytic effects, they have lysis effects, they can destroy the pathogen themselves. So these are the functions of this protein known as the complement, which is the protein component of the inflammatory response. Then neutrophils, small white blood cells, arrive early, like within 6 hours, and engulf bacterial pathogens and die, forming pus. That's why pus is a manifestation of bacterial infection. Pus is a dead neutrophil with a bacterial cell inside. Eosinophils are the main phagocytes involved in parasitic infections and some allergic conditions. Basophils are the main phagocytes involved in allergic reactions. Then macrophages arrive late, like after 12 hours, and they eat everything, pathogens, tissue debris, and they prepare the field for future healing. The natural killer cells, as I mentioned earlier, these are lymphocytes that attack any body cell that does not show a normal major histocompatibility complex due to infection or malignancy, they just attack it. And the antigen-presenting cells, which are the dendritic cells and macrophages, these are the link between the inflammatory system and the immune system. They engulf the pathogen, process it, and present part of its antigen on to the T cells. They present it to the T cytotoxic and the T helper in order to identify the pathogen and kill all cells infected with this pathogen. Notice that within the inflammatory response, the clotting protein cascade is stimulated and the kinin protein cascade is also activated during inflammation. So during inflammation, you get hypercoagulable and also you stimulate the kinin protein cascade and you make a lot of bradykinin, and this bradykinin irritates the pain receptors. That's why the inflamed area becomes tender and painful because of this stimulation of the kinin protein cascade. So the local manifestations of inflammation, warmth, redness, swelling, pain, all result from the vasodilation and increased capillary permeability. And as a result of these local manifestations, you lose the function of this part. Like this big toe joint, this severe inflammation caused by gout, urate deposition in the joint will become red, hot, tender, swollen, the 4 local manifestations. And as a result of that, you get loss of function. In addition to the local manifestations of inflammation, you will also have systemic manifestations. And these systemic manifestations are mediated by release of chemicals known collectively as cytokines. Cyto means cells, kines means movement. So these chemicals move between cells. And this results in fever because some of these chemicals will go to the temperature regulating center in the hypothalamus and will reset it at a higher degree, so your body temperature increases, trying to make your internal environment less comfortable for the pathogen to get rid of it. And these chemicals also affect your nervous system and you feel kind of tired or lethargic, and also will stimulate your bone marrow to produce more leukocytes, more white blood cells. That's why your leukocytic count increases whenever you have infection. And also some of these chemicals will go stimulate the liver to produce certain proteins that increase in any inflammation. So, and they are known collectively as acute phase reactants. Acute phase reactants are non-specific proteins. They are released whenever you have inflammation, any type of inflammation, whether because of viral infection, bacterial infection, or autoimmune condition. And they are examples of acute phase reactants: C-reactive protein, fibrinogen, even ferritin is an acute phase reactant. So if you have inflammation for whatever reason, if you have rheumatoid arthritis, your C-reactive protein goes up, your fibrinogen goes up, your ferritin goes up. If you have ankle sprain, your C-reactive protein goes up because you have inflammation caused by this trauma. So these acute phase reactants are non-specific proteins. They do not tell you what is the cause of inflammation, but they tell you that the condition you have is inflammatory in nature. Also, another systemic manifestation of inflammation is elevated ESR. What do you think of inflammatory response? Good or bad? Actually, it's very good because it prevents infection and prevents further damage, and it limits and controls the infection or the tissue damage. It limits and controls the damage, actually, not the inflammation. Inflammation limits and controls the damage. It interacts with components of the immune system. It links to the immune system, and it prepares the area of injury for healing. So could inflammatory response be harmful? Definitely, if it goes on and on. Imagine if all your tissues are red, hot, tender, swollen, and you lose their functions. Then you're going to end up having multiple organ dysfunction syndrome. Therefore, there should be a very well-organized balance between the chemicals and cells that initiate and maintain inflammation, because inflammation is very important to protect your life. So it has to start very rapidly, and it has to be very aggressive to limit and control the damage. But on the other hand, we also should have anti-inflammatory mediators. So the pro-inflammatory mediators initiate and maintain and stimulate inflammation, and the anti-inflammatory mediators oppose inflammation, so that at the end of the day, you have a well-controlled inflammatory response that only protects you, and it works for specific period of time and does not last too long, and therefore does not harm you. Examples of pro-inflammatory mediators, I do not require you to memorize them: interleukins 1 and 6 and tumor necrosis factor alpha. Examples of anti-inflammatory factors, interleukin 10 and transforming growth factor beta. And as I mentioned, there should be a very well-controlled balance between these two. So in any inflammatory process, you have enough amounts of pro-inflammatory mediators and anti-inflammatory mediators. What if we have a dysregulated inflammatory response for a reason or another? What if you only have pro-inflammatory mediators, pro-inflammatory mediators, pro-inflammatory mediators, and you don't have anti-inflammatory mediators? Then your inflammatory response will go wild, and all your tissues will become red hot, tender, swollen, and you lose their functions. And we call this SIRS, or systemic inflammatory response syndrome. And this SIRS, if not managed properly, will lead to multiple organ dysfunction syndrome, or MODS. We talked already about the complement and the 4 functions of the complement. I'm not going to repeat them. You have them here for your records. And the complement is nothing but plasma proteins that are circulating in an inactive fashion. And to activate it, whether you activate it by antibodies, or they can be activated by some pathogens, and sometimes they can be activated by other plasma proteins. Remember that also the clotting system is stimulated in inflammation, again, in order to make clots, to trap microorganisms, to provide a framework for future repair and healing. And of course, you know from your bio that we have extrinsic pathways and intrinsic pathways. Both are stimulated during inflammation. And also the kinase system is stimulated and activated. And as a result of that, you will have a lot of bradykinin. And this bradykinin, together with prostaglandins, stimulate the pain receptors. And this explains why you have pain whenever you have inflammation. The mast cells, they have the pattern recognition receptors, as I mentioned, and these pattern recognition receptors will either identify any pathogen-associated molecular pattern or damage-associated molecular pattern. Notice that the mast cells are always located at your borders, the borders between your internal environment and the external environment, like subcutaneous tissue, very rich in mast cells, the mucous membranes lining your gut, your respiratory tract, your genitourinary tract, very rich in mast cells. So they are at the borders. And these pattern recognition receptors, once they identified any foreign molecular pattern, they will shoot chemicals. And these chemicals are interleukins and prostaglandins and histamines. And some of the chemicals are pro-inflammatory, some are anti-inflammatory, as we discussed earlier. So the mast cells, when they degranulate, they release histamine and prostaglandins, and histamine initiates the inflammatory process. The white blood cells involved in the inflammatory response and the immune response, we have white blood cells that eat the pathogen, and they are known as phagocytes, like the granulocytes. And we have agranulocytes. Macrophages, by the way, do not have granules. And then we have the immunocytes, which are the lymphocytes, the T cells, and the B cells. And also the natural killer cells are lymphocytes too. And dendritic cells, some say they are lymphocytes, some say no, they are not lymphocytes, and they are the antigen-presenting cells. These terms are important to know. Leukocytosis is increased number of leukocytes. Leukopenia, decreased number of leukocytes. And of course, if you have leukopenia, you will have frequent infections. Granulocytosis, too much granulocytes. And what are the granulocytes? Neutrophils, eosinophils, basophils. Granulocytopenia, low number of granulocytes. Agranulocytosis is very, very, very low number of granulocytes. And it most commonly involves neutrophils. Because neutrophils are specialized against bacterial infections, so when you have differential leukocytic count in an infection, if you notice that the neutrophil count is very elevated, you suspect bacterial infection. And because lymphocytes, especially the T cytotoxic, attack pathogen inside the cells, and because viruses are intracellular pathogens, so in viral infections, your lymphocytes go up, your lymphocytic count go up. Granulocytopenia is marked drop in the number of granulocytes. Neutrophils, as I mentioned, they increase in bacterial infections, and if you have neutropenia, you get very vulnerable to serious bacterial infections. Eosinophils increase in parasitic infections and in some allergic conditions. Basophils are usually increased in allergic reactions. Macrophages, these are the big eaters. When they are circulating in the blood, we call them monocytes. When they are in the tissues, we call them macrophages. And they arrive late and they clean the field, preparing for future healing. Dendritic cells, the antigen-presenting cells, they act as headhunters. They kill the pathogen, they eat it, they digest it, they process it, and they present part of the pathogen antigen to the T lymphocytes, the T helper and T cytotoxic, to generate an acquired immune response. So what are the sequence of events in immune response? It starts by antigen-presenting cells, dendritic and macrophages, that present the pathogen's antigen to the two major types of T cells. They present it to the T cytotoxic, and the T cytotoxic, once they identify the pathogen, they become primed. Primed means what? Now I know you, and I'm able to recognize the body cells that are infected with that specific pathogen. I'm only waiting for orders to come from the T helper cell in order to kill every cell in the body that is infected with this particular pathogen. And also the dendritic cells communicate with the T helper cells, and the T helper cells now will know what does the pathogen look like and will send chemicals to stimulate all components of the immune response and also the inflammatory response. So the T helper cells, the CD4, will release interleukins to stimulate the T cytotoxic cells and the primed B cells, the plasma cells, and the components of the inflammatory response as well. And the T cytotoxic cells, after receiving their orders from the T helper cells or CD4, will attack infected cells with that specific pathogen inside, only against that specific pathogen, not any other pathogen. The B cells, certain antibodies carried on certain B cells, recognize the pathogen while it is circulating in the blood, and these B cells become primed, and these primed B cells, when receive orders from CD4 cells, will differentiate into plasma cells capable of producing millions of specific antibodies, aka immunoglobulins, against the antigen that primed the B cells. And immunoglobulins can directly attack the pathogen, causing its neutralization, agglutination, and precipitation. Antibodies also can activate the complement, and antibodies opsonize the pathogen. They tag it, they mark it, facilitating its phagocytosis by macrophages. And memory cells, these are some plasma cells carrying the specific antibodies against the pathogen, will be stored to fight subsequent infections with the same pathogen. Okay, we can categorize adaptive immunity, this immune response. We can categorize it into two major categories: naturally acquired and artificially acquired. Naturally acquired means nobody intervened. Artificially acquired means some healthcare worker did something in order for you to acquire this immunity. And a major question we need to ask in any type of immunity is, did you synthesize and make the antibodies, or you just received them? Because if you make the antibodies yourself, then your immunity is active. But if you receive pre-made antibodies, then your immunity is passive. So the naturally acquired immunity can be active or passive. Active, like when you are infected for the first time with the flu, for example, you start making antibodies against the flu, and now you have antibodies against the flu, and for the rest of this winter, if you get exposed again to the same flu virus, you can resist. So that's active, naturally acquired immunity. Passive, naturally acquired immunity means what? When babies receive the antibodies in their mother's milk via the colostrum, the milk in the very early 4 weeks of life. It's full of immunoglobulins, so these babies passively receive antibodies, and this is naturally acquired, not artificial. For artificially acquired means someone has to do something. When I vaccinate you against some disease, vaccines usually have weakened pathogens. So I give you a weakened version of a pathogen so that it's not going to harm you, but it's going to piss off your immune system, and your immune system will develop antibodies against this. So it is artificial because I gave you this vaccine. It does not happen by chance. I intentionally gave you a vaccine, and it is active because it was you who made the antibodies. Passively acquired artificial immunity means I inject pre-made antibodies in your circulation, like when I inject immunoglobulins. So I inject immunoglobulins against specific pathogens, so that's passive because you only receive the antibodies, you do not make them, and it is artificially acquired because I intervened and I injected these immunoglobulins in your circulation. And the immune response is cell-mediated, which is getting rid of the already infected cells, and this is the role of the T helper and the cytotoxic T cells, and humoral response, which is chasing the pathogens while circulating in body fluids, and that's the role of antibodies or immunoglobulins. And these are the comparison between cytotoxic T cells and helper T cells, and we have helper 1 and helper 2. And the B cells and the plasma cells make antibodies, and antibodies are AKA immunoglobulins, and we have 5 types of immunoglobulins: IgG, IgA, IgM, IgE, IgD. Immunoglobulin E plays an important role in allergic conditions and also in parasitic infections. Antibodies protect against infection. The degree of protection is assessed by the antibody titer or a specific antigen simply we ask the question, do you still remember what the pathogen looks like? And these are the direct actions of antibodies, no need to memorize them, and the indirect actions of antibodies, opsonization, which means tagging or marking the pathogen to facilitate its phagocytosis and complement activation. And this ends this segment, and in the next segment, we're going to talk about the pathophysiology of the immune system or altered immunity. So let me end this segment here.